Greetings. In the previous video, you have seen how we identify the source of bleeding in this young patient with refractory acute lymphatic leukemia who is waiting for CAR T cell therapy. We found this punctate bleeding, not an arterial sputter. There is no ulcer, but continuous ooze. His platelet count was running in the 15s to 20,000. We transfused to 35,000. His white cell count was in the 200 range. After extensive discussion with the oncology team, we felt that the benefits outweigh the risks of doing endoscopy in severely immunocompromised host. In terms of management of this bleed, you have several options. One, epinephrine injection, but you will cause more damage with more punctures. Cautery is not an option either because of risk of delayed bleeding from the ulceration. So mechanical hemostasis is the way to go. You could also consider a spray, but it is going to be temporary. So we decided to apply a clip on that bleeding spot. The clip application was good. There was deep approximation, but the bleeding continued. So in those cases, you have to figure out where is the vessel coming. Is it coming from the fundus side to the antrum or from the antrum side to the fundus? Where is the blood flow? So you don't know. So you apply a clip on the caudal side or the antral side and see if the bleeding stops. The bleeding actually stopped, but there was another vessel that opened up adjacent to that. You can see right now there is some ooze, and we had to manage that. And we want to confirm that it was actually going to continue to bleed before applying a clip. And we felt that instead of applying it directly on the bleeding spot, we wanted to apply a little bit distally so that we could occlude the feeding vessel and stop the bleeding. Whenever you apply a clip, as you can see, I did not deploy immediately, waited to confirm the bleeding has stopped, and then deployed the clip. That is an important principle in clip application that you should keep in mind. Now that the bleeding has stopped, we wait to assure ourselves that we have achieved complete hemostasis. So important to wait. So there is a little bit of a trickle of blood that you could see now, a little bit coming, much better than before, but you want to control that bleeding also. In order to do that, what do you want to do next? Options include application of additional clips and where to apply, on the oral side or on the distal side. Because the second bleeding site controlled easily with a distal clip application, distal to the site of bleeding, we decided to put that additional clip towards that second lesion, and this has worked very well because now we achieved complete hemostasis. The next step is what do you want to do if there is anything else? We felt that we should we should secure the hemostasis because the patient is going to go through chemotherapy, prepare the bone marrow for CAR T cell therapy. So we decided to put one more clip distal to the second lesion, and then before we came out, we thought that why not apply a little bit of a Purostat. This has been shown to stop bleeding as an additional way of creating a firm clot quickly, given the low platelets that the patient has been having. I'm very pleased to share with you that this intervention has stopped the bleeding and the patient's hemoglobin remained stable, did not require any more excessive amount of transfusions, except for that is required for management of leukemia, and currently undergoing therapy for his leukemia. So, important message: when you see somebody like this with low platelets, low white cell count, have a multidisciplinary discussion, work with the oncologist, and then consider endoscopic therapy. Thank you.